Oh, hello, how you doing?
Hello, John. How are you? Are you able to hear me?
Yeah.
Okay, great. I just reached Georgia. I had a very bad flight. 24 hours I was at the airport.
Oh, you're kidding.
So yeah,
Well, airports are great places to hang around.
yeah, the thing is that they delayed our flight 3 times. So finally we reached because of the horrible weather. We had to come back again to Istanbul. Then I had to wait around 8 hours in Istanbul airport and again come to Georgia. So it's horrible. I haven't slept like 36 hours, but today we will
Oh
do
my
this
God.
webinar.
Dedication. You're just running on
Yeah,
running on adrenaline, right?
I would be very grateful if you little bit help me, okay?
Yeah, yeah.
With
Well,
my
no, I won't help you. I never do. What should I?
just a second, let me change the
No, come on, don't
background.
say, would you help me? Of course I would.
Thank you.
Of course. What do you need?
I need to change my background.
Oh, okay. You
Okay,
don't need me for that.
whiteboard. I
Okay.
don't need a background effects. Oh no, I don't have it. Okay.
Okay, there's a new thing now called the caption at the bottom of your screen. You might be able to translate into Russian in real time. It's a
Yeah,
fantastic. So at the
caption,
bottom
yes.
of your Zoom screen, look at the caption and
Mhm.
play with it. I haven't really
Okay.
totally figured it out, but
I will.
yeah, try to get the most important thing for you, Nagiva, is get the Russian caption straightened out. Okay, so that's the most important thing you can do right now.
Just a
John,
second.
Yes, hi.
it's Ramesh from London here.
Sir, good
Oh,
afternoon.
Ramesh, how you doing?
I'm very good. Okay, I just got your message. Thanks.
You got it. Okay. I haven't seen Ramesh in 5 years. He was one of the first guys I ever televised.
I'm very glad sir got time to join our webinars today. Thank you so
Ramesh,
much.
I was telling him you're one of the first people I televised. Remember that? Way back like 6 years ago, 7 years ago? You're
Sir,
muted,
could you
Ramesh.
unmute
I
yourself?
know,
Yes.
I know. It's been a long time. Thanks. Good to see you.
Yeah, good to
And
see
good to
you
see
too.
Nagis as well.
Thank you so much,
You
sir.
know, when I saw your name, I said, Ramesh, great. How did you get him? That's great. That's great.
Well, yeah.
So, okay, now Ramesh, today is a great big day in video televising technology. They now have captions at the bottom of the screen.
Yeah, I've
Click.
noticed it.
Okay, you can see my English, but also you may be able to get Russian in real time. Of course, you don't need it, but there are other Russians that are not too confident of the English, and so it's nice to have an aid written in front of you. So
Yeah.
try to get the Russian translation, Nargiza.
Okay, I will.
Okay, just play around with that.
Captions. Speaking language. Okay. Let's see. Let's go for Russian. There is no Russian option. There is
Hold on,
option.
give it a
Okay.
second. Sometimes it
Save.
takes a second to get there.
Show
See, okay,
captions.
okay.
Okay, done.
Go ahead, say something. Say something, Nargiza. Go ahead.
Should I say it
Say it in English.
in English? Okay. Hello,
Hey.
everyone. Hello, everyone.
Okay, do you get that Russian translation?
No, it is not.
Not
It
accurate?
doesn't show. No, it is not showing correct.
Does anybody else,
Translation.
can anybody else get it? Because try playing with
I think
that.
we have all speakers today. Anton Kalinovsky. Антон Владимирович, здравствуйте. Good afternoon.
No, it's going to
Dr.
be in
Anton.
Russian, right? Yeah. It's
Andrei
gonna, I know.
Kuzmin.
Good
It's
day.
going to be,
Good
it's
day.
going to be, except
Dr.
for
Aga
Romer,
Dadash
of
is
course.
here.
Hello, hello, everyone.
Hello, everyone. So we are waiting for Abiram and for Professor Chibaro as well. And Dr. Mario is also has to join. So
Okay, let me
let's
get
wait
him.
another like few
Yeah,
minutes.
there's no hurry. We can wait a
Mhm.
minute or two.
Mhm. Abiram, sorry, please let me in. Okay. Could you make Dr. Abiram the panelist, please? John? Abiram Gabita.
Okay, Nargiza.
John?
Yeah, your
One
co-host, Nargiza. So,
Okay, great. So Aga Dadash, Mario Ganal. So attendance is one.
Hi, everybody.
hello, good
Hi,
day.
everybody.
Hello.
Good afternoon, sir.
Thanks.
Welcome.
Hello, everybody.
Hello, everybody. Так. Good afternoon, Doctor Mario. Just a
Good afternoon,
second.
guys.
Good day, Mario. Two Marios. Oh, no, wait a minute. Mario, oh, you guys must be at the same computer, I guess. or something.
No, it's that nobody has sent the invitation to Mr. Kibaro, so I shared my link to him with him.
Oh, good,
Okay.
good.
Uh,
Okay,
Attendance,
Nargiza, you
30
ready?
seconds.
And this is in English today, right, Nargiza?
Yes, today will be in English.
I am so anyway.
No, it's today in Russian or English?
Okay, that's
In
fine.
English.
Thank you.
Yeah.
Nargiza, is it in
Yes.
English or Russian?
In English.
English.
Okay.
Certainly English for me, Nair, and Kibaro.
Well, you know, we're trying to get a handle on this caption, because you may be able to speak it in real time.
Yes, we did it with the Chinese neurotrauma course. Yes,
Oh, good. It worked pretty good.
it worked very well. It was
All
pretty strange to
right.
see us speaking in English and and
This is a big day
listening
in
in Chinese.
video. Oh, this is a big day in video technology, because if you make a video, it's available in real time in 160 languages. Now, there's a difference between real time as translation, because translation is after the conference is done, but this is in real time. As you speak, it's translated, and that's a big day in education.
Yes.
Not just neurosurgery, all education.
Everything. Yes.
This
Absolutely.
tool has become 160 times more valuable. This platform can reach 160 languages. I mean, that's incredible.
Yeah.
Isn't that, Ramesh? That is one of the biggest days since
Yeah,
Zoom
absolutely.
started.
And so many meetings we are missing just because some of the meetings happening in different languages. So if you are able to understand it,
Yeah, we'll be able to see it. I mean, this is a fantastic day. It's been relatively quiet. I thought it would be huge news, but it's creeping in. People will begin to see it.
is it enabled now? Is it working now, or is it still?
I believe so. I don't know it well.
Okay.
You just kind of have to play with it. There's a couple of menu things. Anyways, ready to start, Nagisa?
Yes.
Okay, let's go. 10, 9, 8. Oh, let me get the menu. Speaker. Okay, 10, 9, 8, 7, 6, 5. Oh, hold on. Got that wrong thing. 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning. This is Dr. John Bennett, broadcasting from the home of Neurosurgical TV. We have today the honor of hosting the Russian Neurosurgery Grand Rounds with Nargiza Sartova, MD, from Uzbekistan, currently at the airport. She loves to fly. She loves to hang around airports. Welcome, Nargiza.
Good afternoon, everyone. It's a great pleasure to host today our 7th Russian Neurosurgery Grant Round webinars. Today will be our last webinar this year, and I hope it will be good speakers, topics, and all of us will enjoy. So let me introduce our first speaker, Dr. Anton Kalinovsky, MD, PhD, neurosurgeon and head of neurosurgical department at Federal Neurosurgical Center, Novosibirsk. Today, Dr. Anton will be talking about surgical aspects of approaches for tuberculum cell meningiomas. Sir, you're most welcome to start.
Thank you very much, Margiza, and all participants of this course. And thank you very much for invitation and possibility to talk about any different aspects of the surgery of cell region, and especially for the clinical cases as cell-acoustic meningiomas. A second, please.
Yes, we are able to see your screen. And could you make a presentation mode? Done.
Okay.
Perfect.
Yes, we can see perfect.
Okay, and we will start. Of course, we know that meningiomas of the skull base is not rare, and in the anterior fossa they are very often, and in the region of sella tussica there are about 5 to 10% of all meningiomas who are in the cranial. They are not so big like meningiomas of the fossa ophthalmica, for example, or for the middle fossa or posterior fossa, but they have a very huge neurological deficit. The first is a visual dysfunction, and it's very important for patients. And when we talk about the surgery of this region, of course, we talk about the difficulties of removal of these tumors, because they have very often the adhesion to the nerves, and because there is difficult to manipulate in the tumor or the nerves contact. When we talk about the choice of approach, the first we know that there is two different view on this problem, different maybe religions. The first, when we talk about how to achieve to this region, we remember about the anterior approach, different kinds, and the secondly lateral approach, and very discussable, I think, third third view to this problem, the approach through the nasal region, endoscopic or transnasal surgery. I think it's not, we will not discuss about it, this topic. When we talk about the anterior approach, there is different kinds of these view. The first is subfrontal, one side, or bifrontal approach, the interhemispherical approach. When we talk about the lateral approach, is classical pterional approach, of course, and the different kind of this approach changes, like big approach, the most big is the biggest is orbitozygomatical, or the other side, the small approach like lateral supraorbital approach. When we talk about two different philosophies: the anterior or lateral approach to this region. We must understand and remember about problem when we use one of when we try to choose one of this part of approach. When we talk about anterior approach, what problem we have? The first, of course, this is a frontal sinus. Opening of sinus increase the time of operation and increase risk of complications like infection, for example, CSF leakage. Second one, when we go through the anterior region of anterior fossa, we very often can destroy one of two olfactory nerves and have the neurological deficit after operation. After that, we usually contact with basal veins, and the damage of these anatomical vessels can have problem with venous with vascular complication of the frontal lobes. And when we talk about subfrontal approach, very often we must use the retractors because the frontal lobe must be moved up from the skull base, and this is a problem for the long traction of the frontal lobes, and there can be complications too. When we talk about lateral approach, what reasons are to prefer to use this via to the approach to the anterior fossa? Low risk of infections because you don't contact with the frontal sinus. It's the first. It's very important. The preservation of olfactory nerves, of course. Very fast you can see and open basal cisterns. For example, optical carotid cistern. It gives you ability to remove the CSF and relax brain very fast. And other one is a good visualization of the optic nerve and the internal carotid artery from the site of approach. This is a classical pictures for lateral approach, like the lateral supraorbital approach. The position on the table, it's not difficult. The skin incision is not so big like when we talk about anterior approach, like a bifrontal and subfrontal approach. And this is a classical view from the from outside to inside. The craniotomy is not so big, and visualization of all part of the anterior fossa is very well, from the frontal sinus to the middle fossa, and you can see here all anatomical parts of this area. And of course, when we talk about this approach, maybe one of the good reasons for use it is absence of the brain retraction, because it's easy to open basal centers, and it's very well for brain retraction. When we talk about the middle lesions of this area, the question is what side of approach you can to prefer, left side or right side, because tumor is on the middle line, and where is better to perform the craniotomy, on left side or from side right side, and this is one of the questions for surgeon. This is the first clinical case. You see here the not so big medial size tumor of the celotus region. This is a meningioma, of course. This is a female, 39 years old, for 2 years who slowly had the decreasing of the visual function. And when she was admitted to our center, the visual function was similar for both eyes. You see here the very bad function of the visual function. And here, of course, we don't have the question what side to prefer, because the function of the left nerve and the right nerve are similar, and it depends on the depends on surgeon, left side, right side. Usually, all of surgeons prefer operate from the right side. No any other decisions for to prefer the approach. And what do we see? Right side lateral supraorbital approach, and the visual function before operation was very dangerous. And after 5 days, you see that on the side of approach, the visual function improved, but not so good. But on the other side, from the left side, the function of nerve improved very strongly. Why? When we talk about lateral approach to this region and manipulation in this area, especially when we talk about the meningiomas of celotrusca, usually for this disease, we must understand that the most probably is the manipulation between the nerve who is compressed aggressively by the tumor, because when we go through the right side, the most difficult part of the neural structure is the medial part of the nerve who is on the side of approach. And these manipulations are the most difficult, because when we go through the right side, the best visualization is of nerve from the left side, because this area you can see here is the best for visualization. And the problem is left side lateralized meningioma, woman 47 years old, and the visual function is very well on the right nerve, you see, 1, 0, and very bad for the opposite side nerve, you see, this one. She doesn't see anything over 1 meter from the patient. What side of approach for this case? This is a question for the surgeon. We see here, this is an illustration of this case. When we talk about the lateralization of the tumor, you see it's lateralized to the left side, and the right side is intact, and he didn't compress. And when we talk about lateral approach, we understand that in this area, we have the most problem for dissection and prevention of this nerve. On the other side, when we go through the right, like in this picture, we can prevent the opposite nerve, and like here. The patient was operated through the contralateral approach from the intact nerve, because we don't risk of damage of this nerve, and try to prevent the nerve from the other side from the aggressive manipulation when we decompress nerve and dissect the tumor from the nerve. And look here, you see that this is a visual function before operation and in 5 days after operation. The nerve from the approach, is intact, the 1.0, and from other side, we have the very good improvement on the visual function. Other patient, right side localized meningioma with a compression of the nerve. Patient doesn't see anything on this nerve for several months. From the other side, the visualization is very well. The function of the nerve is good. And in this case, we know about the same principle, and we choose the same tactic for approach from the intact side, from the left side for this case. This is a CT, and this is a short video. Excuse me. Second, please. The classical lateral supraorbital approach, not so big craniotomy, the dura is opening, this is the frontal lobe, left side, dura is fixed, and we go to the...
Dr. Anton, we are not able to see your video.
Not visible.
Yeah, not visible.
Oh,
Yeah, try restarting the video.
excuse me.
Okay,
Okay.
no hurry, no hurry.
Okay, but without video, of course.
Okay, okay, no problem.
Next picture, you see? Do you see?
Yes.
Yeah, we can
see
see.
it.
Mhm.
Yeah, okay.
Excellent
This is the
result.
after surgery, yes. You see, this is a contralateral approach from the left side, and the tumor was removed. The nerve from the side, from the left side, is intact after operation, but after operation, we see the improvement on visual function from the nerve from the right side to the 0.1. This, I think, is very good result. For 10 years, we operated 124 meningioma of this region. This is general information about patients, age, size, lateralization. Ipsilateral for patient, 47 patient who for whom the visual function wasn't different for every nerves. For 77 patients, we used the strategy for of a contralateral approach. We tried to prevent compressed nerve and save it and improve the visual function. And result, when we talk about nerves, blue is nerve ipsilateral to approach, and gray is a nerve who is a contralateral to approach. You see that the improvement of function is better for nerve who is opposite of side of approach for this localization, and is a reason to use this conception to prevent visual dysfunction for tumors of this region. Analyzed the result, we found that the risk of visual deterioration is visual dysfunction less than 0.1. Big size of the tumor because it's difficult for manipulation and dissection of nerve and prevent of this function, and the time of visual dysfunction over 12 months. And of course, density of tumor, but we can't understand really the density before operation. It's very difficult. And conclusions are the lateral approach as effective and useful for surgery of this region, my opinion. And decision of the size of approach can be oriented on this result of our surgery too. Thank you very much.
Thank you very much, Dr. Anton, for perfect presentation. Anybody has questions from the audience? Today we
Yeah.
have two moderators, international and Russian. So Dr. Andrei Kuzmin from Chelyabinsk and Dr. Mario Ganau from Oxford, United Kingdom. So
Hello, everyone.
hello.
Can I have
everyone.
two questions to Anton?
Yes.
Yeah.
Okay. Thank you, Anton, for great presentation, for nice examples. I have two questions. The first one, do you use eyebrow approach, and what do you consider? Is it a lateral supraorbital approach or it's like direct supraorbital approach? This is the first one. And the second question is about the decompression of optic nerve in its canal, membranous part and osseum part. And is it, how often do you decompress optic nerve in its canal, and is it difficult to decompress if you do it the optic nerve from the contralateral side? Thank you.
Thank you very much for the question. The first question, I prefer to operate the classical lateral supraorbital approach, but for this region, especially for the meningioma of Selatutica, we perform the craniotomy a little bit anteriorly, like the craniotomy through the eyebrow approach, because when we change the craniotomy and move it anteriorly, you have a lot of space for manipulation between the nerve and the tumor. What to prefer to for the skin incision? I think it depends on the neurosurgeon. It's not difficult. It depends on the surgeon. Eyebrow approach, lateral supraorbital approach. This first question. Second question is about the nerve decompression. When we talk about the Selatutica meningiomas, where the matrix localized on the Selatutica, they are not invasion to the optic nerve. If the optic nerve is compressed, it will not be the Selatutica meningioma. Usually, this is the anterior clinoid meningiomas. And there, of course, you must to open the optic canal, but the approach will be other through from the side of tumor, because it's difficult to open opposite side.
Thank you.
Thank you. Any other questions?
Yes,
Dr. Mario?
yes. Basically, I just wanted to ask Dr. Kalinowski, out of his large series, how many cases of anaplastic meningiomas has he got? And in those cases, what was the Simpson grade achieved?
Okay, I don't remember the histology, but I'm not sure that any one of these cases was anaplastic, because it's very rare for this area that it will be anaplastic or atypical meningiomas. I don't remember.
The question is mostly related to the fact that I've been working a lot on adjuvant radiotherapy and radiosurgery, particularly for grade 2 and grade 3, and just wanted to check whether this is something you consider as a adjuvant strategy, or whether you just follow up patients and then if there is any recurrence or residual, you decide to consider a second stage procedure.
Oh, thank you. We didn't count the number of recurrence cases, it's rare, but usually for this area, the Simpson degree of resection is 2.
Yes.
And usually we don't visualize after surgery the part of tumor what wasn't removed. And we didn't recommend them other kind of radiological treatment.
Yes. Yeah, I suppose that in reality, a better degree of resection can be obtained through an extended endoscopic endonasal approach, simply because you can drill more extensively and therefore remove most of the bony structures that might have been affected by an extension of the meningioma in advanced grades, I mean 2 or 3. But anyway, thank you very much. It was a nice case series, very good exemplificative case, excellent images. I really enjoyed your talk. Thank you. Thank you.
Thank you so much. Dr. Mario, could I ask you to introduce our second speaker? Professor Ramesh Nair. Could you unmute yourself, please? Yes.
Yes. So then the next speaker that I was supposed to present is Professor Kibaro in reality. Are you happy for us to go ahead with him?
Okay, whatever.
Professor Kibaro is has a long track record of minimal invasive and skull-based surgery. Professor Kibaro currently is a professor of neurosurgery at the University of Siena, and has moved to Siena from University of Strasbourg, where he has been working for over 10 years. He's a good friend of mine. We have written so many papers together. He's an excellent surgeon and a fine scientist. Today he's going to describe his experience on skull-based chordomas. Professor Kibaro, the floor is yours.
Can you see my screen?
Yes, perfectly.
Yes, we can, perfectly.
Okay. Thanks very much to the Russian team, and a special thank is for Mario Ganao. He just said we are a very good friend, and I am very happy to be here today in a very nice education day to share my experience. Not comfortable to disclose, and approaching the clival region is very important to know, establish, and define its anatomical limits that are superiorly the cellular floor, the sphenoid sinus, and the anterior floor, inferiorly the anterior arch of C1 at the odontoid process, and laterally, of course, in its upper part, the ICA, and in the middle clivus is the sixth nerve when intradurally. This is a very nice publication from Amin Qassam. It was published 15 years ago, but it is always a very nice reference. And this publication showed very nicely, very beautifully, with direct specimen dissection and schematic drawing, the relation between all neurovascular structure that are in this complex and deep-seated region. And what is important is just to know, what is important is to know the importance of the Vidian nerve, and also that this very nice anatomy is almost always disrupted or changed by the presence of a lesion, and sometimes not recognizable. So we classically approach the clivus through an anterior or a lateral approach. The anterior one could be transsphenoidal or transoral, and the lateral one could be anterolateral, posterolateral, or in very selected cases, subtemporal. Now, what's actually the rationale for this approach, the anterior approach, endoscopic approach, is that artery and nerves are always posterior or lateral to the tumor we are going to approach, and the brainstem is always posterior. So, what's actually the advantages of this technique? There are some advantages that are intrinsic to the endoscopic approach and philosophy, and especially you can get a early lesional devascularization. You can get a very quality, a very nice resection. You can minimize very much all the manipulation of neurovascular structure. And finally, you can achieve a large panoramic, closer up, and multi-angled vision. So the key feature to approach the clivus depend from which part of the clivus we are approaching. In its upper part, we should pay attention to the ICA and the pituitary gland. We can slip this about the transposition, as is a very difficult procedure, as sometimes, although seem very nice, we cannot achieve a satisfactory results. And the basal tip perforators. If we move down to the middle clivus, we should control the second gen of ICA, the sixth nerve when you are intradurally, and you can sometimes face very annoying venous hemorrhage from the basilar plexus. So, going further down, the key to bear in mind are the parapharyngeal ICA, and especially the vertebral arteries, and also the epiglottal canal and the occipital condyle. Now, what is important? This is a surgery that should be performed in a supine position, where the patient should be in a slight antitrandermal 20 degree, and it's very important to have routinely IGS with CT and MRI fusion. Be always equipped of a microdoppler, and would it be important to use 0 and 30 degree scope, of course, with an HD camera, and have always with you some hemostatic agent. And this surgery, in my opinion, is better performed by 2 surgeons. That means 4 hands, but you also can do it with 2 hands with an holder. But anyway, you need an holder, as this is exactly as the is a microsurgical technique. You cannot do it through using just 1 hand. Now, what you should do? We start with a 2 nostril approach. This middle turbinectomy is mandatory. Posterior ethmoidectomy, resection of the posterior portion of the septum, and I wrote down possibly, as if you are approaching extradural lesion, you may avoid it, but I would suggest always to make to elevate a nasoseptal flap, an adult flap. And anyway, to avoid any conflict of the instrument, you should achieve a very wide sphenoidotomy. So to go further down, you need to remove the vomer and the sphenoid floor and all the tissue of the soft tissue that are below and around the Vivian. And the bone removal usually is tailored to the lesion extension. That means it could go from the sella down to the foramen magnum. Now, this is a cadaver specimen dissection showing a very panoramic view. You can, with this one, you can control all the clival section, the upper, the middle, and the lower one. Now, two main challenges. When the lesion is going laterally and behind the ICA and the cavernous sinus, of course, and if there is an extension down to the occipital condyle, the C1, C2, this is the craniocervical junction, probably this is the instability we can get, so should pay attention. This is you can find this is a very nice, another nice publication from the Kassam team. Now, this is a very difficult case with the tumor going on in the cavernous sinus laterally to the carotid and going also behind. So the only way to get this lesion is to couple a midline to a midline approach, a transpterygoid approach. So we are going to see few example. This is an upper clivus lesion. So as we already said, the key features are the ICA, the pituitary, and the basilar tip perforator. This is the pre-op, the post-op, and this is the perioperative images at the end of the resection. It's very beautifully basilar, very clear basilar. Sorry? Sorry, somebody said something?
No. You
Okay.
can continue, sir. Mhm.
Okay, thanks very much. I'm sorry about it.
Mhm.
So this is a middle, is a lower, this is a middle clivus lesion with an intradural extension going through the brainstem. In this case, we know that what is important is to pay attention almost always to the sixth nerve intradurally. And you can see at the end how the sixth nerve coming across has been beautifully respected. So this is a bit more complex. This is a lower clivus going to the craniocervical junction, and you see we already know the basilar plexus, the second genu, but in this case, more important is the vertebral artery and the craniocervical junction instability. We already said that if there is a lateral extension, you should make a transpterygoid approach. You can see here in these images here. And in case of infrapretus ICA extension, you should sometimes make a eustachian tube resection that, as you know, could be complicated by a serious otitis. Now, I try to make it very short, and this is a video about a upper clivus chordoma resection. We already made a very wide sphenoidotomy. We're starting to drill the clival recess, and you can already see coming up the tumor behind and with the CSF. And you can see that we can already start to take out the tumor, and this is a very old video, and you see already coming up the basilar artery, and we try to dissect. This is a very hard tumor, difficult to dissect, respecting all the basilar perforator, and you can see that at the end we could manage very well, and this is no easy surgery, but finally you can say that you got a gross total removal, although talking about chordoma is not very easy to discuss about gross total removal. This is the nasoseptal flap line over, and now we can see another example. This is a middle lower clivus lesion. Okay. So you can see here the mid-turbinectomy. We elevate the nasoseptal flap, and we carry on with a wide sphenoidotomy, and we try to flatten and to remove the floor of the sphenoid to go farther down, and you already see the chordoma. In this case, it was I would say easier, as this lesion is much more soft and with a jelly consistency, and we can take it out very easily. And at the end, you will see that all the basilar and almost down to the vertebral are visible, and this is something that should be done very carefully, always to respect all the very eloquent structure. And you know, this is the end, you can see. So I would say that this is a surgery that, if you are well prepared, is not difficult to manage. But now, just I show you this very small video to tell you that you should always very well equipped, and also you should be calm, and also keep the calm. You know, this is we are just starting. We do see the both carotid on the side, and something happened. So everybody, there was panic, and there was what is going on probably is the carotid bleeding, and at the end we were able to manage and to understand that it was maybe the intercavernous sinus bleeding. So we manage it with a bit difficult, but anyway, we can at the end we're able. And what is important, as I told you, to have always with you some hemostatic agent as the active thrombin, and you see actually we manage the problem in 2 seconds. So what is important that you should always remember that this surgery has a lot of pitfall. So the CSF leak and meningitis is the most important. Remember that we started with 20% CSF leak and 15% meningitis. Now we are about 4-5% CSF leak for this very large, for this extended endoscopic approach. And an issue is also the CCJ instability. So be prepared to make the posterior stabilization. So excessive bleeding. I wouldn't be shocked if you consider a staged procedure. You can say that it's a very long procedure, very big bleeding today. So you can consider to make today, maybe you can plan today to make today the approach, and tomorrow or a few days later the resection. Very often you can get just a very narrow corridor, being the carotid very close to each other, or if you are sometimes scared, but you should try to have a very large corridor, and always the ICA injury. So, in conclusion, the endoscopic approach should be nowadays the armamentarium of any modern skull-based surgeon. Do not forget the microsurgical approach. It could be very useful, and sometimes you can combine. These are not minimal invasive approach. People try to say through the nose, no scar. Yes, that's very nice to say, it's nice to see, but actually they are very maximally invasive approach, and almost always we don't reconstruct what actually we do, or very little. The learning curve is very steep, so go to the lab, as this is a different anatomy, is different comparing to traditionally we learned. And this surgery should be performed by 2 surgeons. In my opinion, it's better if there would be 1 ENT, 1 neurosurgeon, and to have a very nice partnership and to share different competence and expertise. But could be also 2 neurosurgeons. Thank you.
Thank you very much, sir, for the nice presentation. Any questions from the audience, comments?
Yeah, I would like to start. Want to congratulate Professor Kibaro. Excellent presentation, very much educational, step-by-step discussion of the surgical planning and intervention. One of the questions that I have, given my area of expertise in spine surgery, regards approach to lower clivus chordomas. Now, the issue is that oftentimes they also require, as you have nicely showed, supplementation with instrumentation from the back. However, the materials and instruments that we have available for this type of craniocervical stabilization still rely on titanium. And the problem with titanium is that if there is a need for any proton beam radiotherapy, obviously, this would represent a contraindication. Do you think that we will ever reach a stage when this limitation will be overcome or not?
Yeah, I think now that there are many, there is a Switzerland company that is doing a new material in PIC, and I understand that the problem is that we try anyway always to perform a proton therapy if possible later. So if the instability could be managed with a hard collar, and we prefer to make before operation, and we leave the stabilization to be performed after the radio or proton therapy. But I know this is this is actually this is the issue, the current issue. I don't know if it would be easily solved out rapidly, but I think we are in the good way.
Thank you. Thank you so very much. Thank you so very much. Any other question from the floor?
Thank you, Professor Kibaro. Nice, excellent expert talk. Nice presentation. I have one question. Duroplasty and the reconstruction of the wound is the main issue and is the challenging problem. Do you have any tips to for us how to reconstruct the place of the wound effectively?
Actually, what we do routinely is a gasket seal reconstruction and coupled with the nasopseptal flap. If you got a very nice nasopseptal flap and you make a check 1 week, 3 weeks later, that to be sure that the integration, the nasopseptal flap, you will have the chance not to have any CSF leak. But always this is the big problem of this surgery. But we make just a gasket seal. If we can have some rigid stuff to put and to hold your construct in place, it will be okay. So we use also some fat, some fascia lata, whatever. But if you can have a good, nice reconstruction coupled with your nasopseptal flap, I think that you will reduce remarkably your risk of CSF leak.
Do you use lumbar drains and balloons, nasal balloons?
We use nasal balloons. We use nasal balloons. Now they are the very nice new nasal balloons. I don't know. I can't remember the name. The blue one that they adapt themselves to the cavity without putting a lot of pressure. This is just to hold inside for 7 days the construct, but it's not really if we are satisfied for the nasopseptal flap lying over, we don't use a nasal balloon, but we used to use the lumbar drain, and we don't use anymore. And we believe that you can favorize an empty space, and so the lumbar drain would favorize your CSF leak.
Okay, thank you so much.
Thank you very much. Let me introduce our next speaker. It's a great pleasure to introduce Dr. Ramesh Nair, DNB, MCH, DNB Neuro, FRCS, consultant skull base and neurovascular surgeon, head of the neurovascular division, Charing Cross, St. Mary's Hospital, Imperial College Healthcare from London. I personally know Dr. Ramesh Nair, and I'm very glad to be during the conferences, listen to your lectures, to your experience. And today, the name of the topic will be choice of approach to olfactory groove meningiomas, personal philosophy. Sir, welcome.
Thank you.
I'd like to say a word too. I'd like to welcome Ramesh. Ramesh has been a long time user of this technology, and we appreciate his support. Welcome, Ramesh.
Thanks, John. Thanks, Nagisa, for this invitation. As I was telling Mario, the honor is mine to be among the neurosurgeons, special neurosurgeons here. I will start sharing my screen. First of all, I would like to also thank the previous speakers, Professor Gibaro and Kalinowski. I enjoyed those talks. Those are the topics which I am also very keenly interested in. Let me start sharing my screen so that you can see it.
Yes, we can. Presentation mode.
Yeah.
Done, sir. Yes, perfect.
Thank you. So, Professor Kalinowski's talk, I think, is fairly similar to the talk I have prepared. Essentially, the olfactory groove meningiomas are fairly adjacent to the tuberculum area. When we talk about the area here, which is outlined in the yellowish color, there's the area where you have the cribriform plate and the olfactory groove where the tumors arise from. Just behind it, you have the planum and then the tuberculum behind it. But in reality, we know that the tumor grows from one side, but then it also can extend into the adjacent areas, making the distinction quite blurry, because the tumor from the olfactory can also invade into the planum area, also into the tuberculum area, also into the optic canal or the lesser venous vena. So large tumors will get blood supply from the floor around the structures, even though the original the origin is from a very focal area. So it is important to know the approaches and the dilemmas in the approaches for a surgeon for fairly common to all these tumors around this area. So that's why I particularly like Dr. Kalinowski's discussion about the side of approach, which is a dilemma for most neurosurgeons, and which side to approach, whether you come from the ipsilateral side or you go from the contralateral side, which we call a cross-court approach, and depends on the side of visual loss and which nerve is the better nerve. And so there are, isn't that been discussed, so I will not touch upon it. But the important bone, the anatomical point we need to look at here is the ethmoid bone, where you have the olfactory grooves. And then it got this perpendicular plate and the crista galli and also the orbital plate. And this is the origin of the olfactory groove meningioma. But the important thing is the blood supply. For all the meningiomas we deal with, once you know where the blood supply is coming from and the origin of the tumor, then you probably would have won the half of the battle. In this case, the olfactory groove meningioma, they take its blood supply from the anterior and posterior ethmoidal arteries. Those arteries arise from the ophthalmic artery, which is a branch of the internal carotid artery. So essentially, a tumor of the olfactory groove is supplied by the internal carotid artery. But also it takes the meningit supply when it secondary parasitize the flow or the planum or the optic roof or the tuberculum. They get blood supply from other arteries like recurrent meningeal artery, which comes from the ophthalmic artery again, or the artery of foramen rotundum, or other meningeal arteries around this region. So these are all arteries which can contribute to the blood supply. But the primary blood supply often comes from the anterior and postmedial ethmoidal arteries. And so knowing the location and dealing with it as soon as you can will give you a best strategic advantage to deal with the tumor in the first instance. So when we talk about the approaches, my personal philosophy has changed with time as well. Some of these tumors, which, this is a big tumor which I operated in 2014. But when you look at it, you can operate it through a subfrontal route, either through a bifrontal craniotomy, which has been the traditional way to operate these tumors. But as we've discussed before in the previous lecture, that you are traversing the frontal air sinus, you're dealing with both frontal lobes. There is a manipulation of both frontal lobes, but it gives you a wider exposure. When you do a bifrontal craniotomy, it gives you a wider exposure, but you have to deal with the frontal air sinus as well as the sagittal sinus. One may have to cut the sagittal sinus at the front and also divide the forks, but it gives you a wide panoramic view of both sides. But the lateral approaches, which is which is what I want to talk about, is the where you go laterally or lateral supraorbital approach, what I call a modified pterional approach, is where you come from one side and deal with the tumor rather than trying to manipulate both frontal lobes. Here, in this case, this was a bifrontal approach I did, but this is the case I'll probably do it unilaterally. My intention will always be to avoid the frontal air sinus and go lateral to it. So if you can avoid breaching the frontal air sinus, it's probably better that you avoid the complications related to the frontal air sinus, such as infection or a leak of CSF subsequently. And there are other approaches which we have already heard about in the hemispheric approach, which is not unusual, and also the supraorbital approach for smaller tumors. But there is some other approaches which I don't do, subsinus approach, which is just under the frontal air sinus, which is a smaller operation, smaller craniotomy, but you will be traversing the frontal air sinus. And then also the supraorbital approach, where you take off the small part of the orbital, the frontal bone, just above the eyebrow. Again, that is suitable for selected cases of anterior skull-base meningioma, but not necessarily for such a large, big tumors. So we have seen here the various approaches. Here also, one could do in selected cases, come from below where you deal with the base of the tumor first, where the hyperosteotic bone and the blood supply and you avoid any manipulation of any structures. The endoscopic approach has an advantage that you will be dealing with the optic canal invasion of these tumors. These tumors often invade into the optic canal, then compress the optic nerve. When they do that, they often do it from the medial side. And that may be difficult when you come from one side cranium, but that may be more straightforward when you come from endoscopically, where you can decompress the optic nerve all along. But these endoscopic approaches are not suitable for all cases. We'll come to it a bit later. Standard frontal craniotomy, bifrontal craniotomy, you will harvest a pericranial fat so that you can close off the frontal air sinus to avoid CSF leak. But my approach has been to do a unilateral approach, where I call it a modified TNL approach. And this is not the craniotomy for all cases. Just this extent of the craniotomy varies from case to case, and the extent of the frontal air sinus. The more frontal air sinus you have, the more lateral extent of the frontal air sinus you have, I will move my craniotomy a bit more posteriorly. So it becomes like a TDonal craniotomy. But if the frontal sinus is very small or non-existent, I'll move the craniotomy more frontally. So it becomes like a more frontal craniotomy and then a subfrontal approach. And the incision also will vary from bicoronal incision. If you're going more frontally, you have to get a very low exposure here. That means you have to do the skin incision quite onto the contralateral side. But if you're coming very laterally, you will not need to go across the midline, or you come up only up to the midline for the skin incision. So this is the way we've been doing, and the position is quite important as well, to make sure that you utilize the gravity for the frontal lobes to fall off, and also turn the head maybe 15 to 20 degrees to the contralaterally. So you have the tumor directly on the surface. And we have also looked at the visualization angle when we deal with such tumors. Bigger craniotomies can give you, but this lateral craniotomies can give you the sufficient exposure of the whole of the skull base. You don't necessarily need to do a bifrontal craniotomy to tackle a tumor which is coming from this area. So let's see one case where, but last year, this is a young man of 47 years of age, a colleague of mine, husband of a colleague of mine, came with a single episode of seizure with a large tumor, mostly arising from the posterior olfactory groove and then extending backwards. So in this sort of tumors, it is important to know where these tumors arise from. And if I'd like to think in bigger tumors, to think back in time and see how they originated initially. You can imagine that at some point it was a small tumor at the back of the olfactory groove. Then when it grew, it pushed up the cisterns, pushed up the arachnoid layer, investment of the frontal lobes, and also when it grew backwards, it pushed the optic nerve cistern backwards, and also the suprasellar cistern, which is behind the optic cistern. So there will be two layers of arachnoids at the back of it, so which is safe. And the structures like infundibulum or the optic nerves, everything will be behind the optic cistern. So then you know that you are safe from damaging those structures when you debulk this tumor. So those sort of cisternal anatomy is key in understanding and planning this operation. So a couple of things. One is the origin of the tumor and the displacement of the cisterns in many tumors. This is true for all the many tumors in anywhere in the cranial cavity, and also the blood supply. So these are the things which one needs to think about before operating these cases to make your operation much more strategically easy. So this tumor, you can see, it is quite tough. The brain is quite tense here. And this is the right side, just marked out so at the back of your exposure for a modified TNL craniotomy, you are at the back of the tumor where you're accessing the cisterns. Even though the brain, you can see, I'm using some pressure with my suction here, but with time and patience, you drain the CSF around the opticocarotid cistern so that with time, the CSF will drain out and you have enough space to tackle the tumor. So this is why you don't need to make big openings under the cranium or the dura so that you can tackle these big tumors even with the smaller operations. Smaller operation means so the brain is relaxed now, and you can see that the tumor is now being debulked. Tumor can be debulked in many ways using ultrasonic aspirators or even in cases where the tumor is very tough, you may have to use scissors or even other instruments where you can make sure that you get a good debulking. Once the tumor is all detached all around, then only you make an attempt to try and take out the tumor. Here, I could have debulked a bit more, but I have ensured that the tumor is all completely detached. And this is a surface one hope to see at the end of the operation. You want the tumor to be a bit raggy and not shiny, because you want to leave the arachnoid onto the brain, not onto the surface. Here the tumor is taken out, big tumors, but they come out nicely if you have taken off, if you have followed the arachnoid layers, that you mean, then you know that you haven't damaged any of the vital structures. And so this is the opening for this big tumor, and the optic nerve is seen right here. And the incision is quite usually parallel to the base, and you don't need to expose a lot of brain here. So we will move around, and this is the what I want to show here is the edges of the craniotomy here. You can see the frontal layer sinus shows some inflammatory pathology. So it's all the more reason that we should try and avoid breaching the frontal layer sinus if possible. So if you have navigation, if you mark out the frontal layer sinus beforehand, that is quite sensible to do that. And also the craniotomy extends from here to here. So you're just skirting the frontal layer sinus, you never try to open it. So that will be at least one less botheration for you for the postoperative recovery for such patient. For example, this case is a young man, an unfortunate case where he had already lost most of his vision by the time he came to us. It's unfortunate in this day and era that people tend to lose their eyesight before they get a scan done, and then here you can see a big hyperostotic plaque at the base of the tumor, but also the tumor is spilling into the diaphragm, the cella turcica, and pushing the structures behind it. So even such tumors, at the back of the tumor, you can see the anterior subarachnoid complexes. They are pushed backwards. The A1s are both lifted up, A-combs and A2s. So this is a sort of, sometimes it's radiologic, we call a guard of honor sign, where you see it in tubercular meningiomas and other tumors of the anterior skull base, where everything is lifted up. And the tumor is extending backwards, almost to the sphenoid ridge, and you can see the extensive hyperostotic area here. But the advantage of this case is that you can see in T2 that there is a good clear CSF plane, and that gives you a hope that there'll be a good arachnoid plane all around it. In this case, I believe I did a left-sided modified tedial craniotomy, and the choice of approach is often in this case, mostly central, is uniformly in the middle, but there is more extension, slightly more towards the left side, and the cortical mantle is slightly thinned out on this line. So I decided to go on the left side, but it depends on which side. If it's equally in the midline, one could potentially go for the right side, which is the non-dominant hemisphere. Incision is this is the incision. Head position is shown here, and head is tilted downwards so that the frontal lobe will fall backwards. And the procedure is, this is a sort of setup for what I'm doing here is the pulling the temporalis backwards. I'm not making a cut on the temporalis. I'm just pushing it backwards so that this is your area of entry. You don't have to do a posterior exposure. What your exposure is more anterior around the tidion and the frontal base. Here you can see the incision is V-marked. And just please note the retraction system as well. The retraction goes up, not towards the face or over the orbit. I had cases where there was orbital compartment syndrome with pulling off the scalp flap over the eyes. And this is the flap. And you make a flap like this for bigger tumors, but smaller tumors, you make it a smaller flap. And the temporalis is pulled backwards. It's not cut. It's no separate temporalis flap. And the exposure will get you to the base of the anterior cranial fossa. This is in line with the anterior cranial fossa, just on the orbital roof. So this is the exposure you need. The sylvian fissure and the tidion is here, and this is the dewlap. You can see the brain is quite tense in such cases, but once you access the cisterns, without without putting too much pressure on the brain, you should be able to drain off the CSF so that you get a good relaxation. But in certain cases, when the brain is too tense, one can even remove this bit of orbital rim to get you a very basal exposure. So as soon as you go through the base, you know that the tumor is attached to the base. So that is the sort of initial step. One get to the base and dissect off the supply to the tumor, and then debulk it. Here, the tumor is being debulked. So I'll just move it forward. And this is the kind of instrument which we don't normally use. You can see here, it is the instrument we call debrider, which with the ENT surgeons often use. But it's quite useful. I don't use it normally, but in this case, a big tumor, massive tumor. And it's quite, once you know that you're within the tumor and there's a lot of tumor around it, this will cut the tumor like anything, because it's like a tube, suction tube with a rotating blade inside. Once you've done that, once you've taken off the tumor, you then reel off the hyperorthotic bone at the base, so that you take time to take as much as bone as possible. And this is an area where you could potentially enter into the ethmoid sinuses or the paranasal sinus or the sphenoid sinus. So this is towards the end of the operation where you don't want to cause any leak, but it is important that you remove disease as much as possible. And also you can see that the incision is fairly parallel to the skull base. And that is a unilateral approach to remove it. But large tumors, they are not that difficult. Once you've taken off the tumor, you have plenty of space. The brain swelling can be accommodated by removal of the tumor. And the small tumors, they are also, you don't manipulate the brain that much to get to the tumor. But the medium-sized tumors are the tricky tumors, especially when they cause a lot of swelling around it. For example, in this case, there's a lot of brain swelling around it. Even when you try to open the brain, you can see that the brain is all, this is a small tumor, but the brain was quite swollen. In this case, if you try to open it and then push the brain, it's likely to, this is a right frontal craniotomy here. Because the frontal air sinus was quite small, it's more like an anterior craniotomy rather than a lateral craniotomy here. But because the brain was so swollen, I had to remove a rim of orbital rim so that you get a very low basal exposure towards the base of the tumor. This shows you the craniotomy here and the rim that is taken off. So that gives you a very low exposure. Another case where the orbital rim was taken off, but they're not regular cases. Once in a while, you come across a medium-sized tumor with a significant brain swelling, and once you've done the craniotomy, that means that you may have to consider some skull-based approach to avoid frontal brain damage. But some cases like this, fairly small tumors, even though there is some swelling around it, you can see that on the coronal plane, it's not extending very laterally beyond the optic nerve or the orbital globe. These are cases where one could consider endoscopic approach, especially if there is significant extension towards the paranasal cavity. These are the cases I would consider endoscopic approach. There is still a debate in the international circle whether one should consider endoscopic approach for these tumors at all or not. But in my mind, there is a clear indication in selection of cases. It's all about selecting cases. And for example, this is the same case several years later, follow-up scan. This is another case, a 61-year-old female with a growing tumor in the olfactory groove. But these are all ideal cases for endoscopic operation. So she has had surgery a long time ago, and she's doing really well. So there are cases where one could consider endoscopic operations, and not for all the cases. You've got to select the cases appropriately. And this is same for tuberculum cellular meningioma, which are an excellent indication in some tumors, not for all the tuberculum cellular meningiomas for endoscopic approach. But I will finish my talk by just to conclude some of the key aspects which I think is important. The principles of meningioma surgery, as we know, dissection, devascularization, and debulking and detachment, they're all part of the meningioma operation. But for olfactory groove meningiomas or anterior skull-based meningioma, I try to avoid breaching the air sinus. I try to go unilaterally. And I don't have a very strict view on where to place the craniotomy. I will move my craniotomy back and forth depending on the extent of the lateral frontal air sinus. and the side of the operation also determined by the extent of the tumor. And in certain cases, I don't hesitate to use the extended endonasal approach. With that, I'll stop here, and thank you very much for listening, and thank you for the invitation once again.
Thank you very much, sir, for perfect presentation, for all details. Any questions or comments from the audience?
I would like to start 1 second with my congratulations to Mr. Nair. Really a masterclass presentation. The question that I have is basically related to the exposure. I've seen a very large flap as per our principal flap, much larger than the craniotomy itself, so that you can factor all possible need for the compression should it be needed. And I would like to ask what is the philosophy at Imperial with the use of 3D endoscope and potentially the use of exoscope as adjuvant to microsurgical resection?
Thanks, Mario. I think the question is about using 3D endoscope. For extended endonasal approaches, we use standard endoscope, the 0 degree and 30 degree. And we have used the 3D endoscope. It's mainly a technical difference. And I didn't find it much different to using the 2D endoscope, because the view you have when you use the endoscope is a 2D view when you look at the screen, and what you have that kind of depth perception when you move in and out. And because we've been operating endoscopically for many years, that is not much of a concern, even though you have only 2D perception. 3D can be a bit more advantage, but I don't find that much of a difference when I used it. So I don't use it anymore. And in terms of exoscope gives you an excellent optics and the clarity, and I found it quite useful in certain position. In standard supine craniotomy and lateral supratentorial craniotomies, I didn't think it is absolutely made any much difference, even though from a teaching perspective, from an observer perspective, you have big 4K screens, and you can also have a 3D screen. And for teaching purposes, it's quite good. But what I found the exoscope useful was in certain cases where you use certain position, like supratentorial, supracerebellar infratentorial approaches, or some of the posterior fossa lateral approaches and the lateral approaches. I think it is quite useful that the surgeon doesn't have to exert that much of a problem. Their position can be a bit more easy when they use the exoscope and look at the screen. So exoscope can give you a slight more clarity, but in terms of the actual operative technique or some of the outcome from the procedure, I didn't find it much difficult. And also, you also mentioned about the extent of craniotomy. The craniotomy, even when you make a big flap, the dual incision can be very small. All you need is that if you can get to the base, if you can get to the base and debulk it, then that should be that much of exposure should be enough for you to take out big tumors. So not necessarily you expose a big part of the cranium or expose the dura, but you trying to visualize the base of the tumors, that if you can access and debulk, then you can, once you create a space by removing the tumor, you can go in and out, and then see a lot of areas where you can see it. But using endoscope after microsurgical operation is another option which I used in some cases, especially when you want to see where areas which are blind corners. Like, Professor Kalinowski was talking about going behind the optic nerve. If you come from an ipsilateral side and if you see that the part of the tumor is blind behind the optic nerve and the carotid artery, that's the time when you can use an angled endoscope or a 0 degree endoscope to look at the corners. And I use it for aneurysms, and I use it for some of the suprasellar operations. I hope I have answered your question.
Perfectly. Just an add to this. I know at Imperial you have a very long tradition with the use of intraoperative ultrasound here in Oxford, we have one of our neuro-oncology surgeon, Vas, who contributed a lot to this research while he was working with you. Do you routinely use intraoperative ultrasound in your cases?
So for my skull base and vascular work, I use the ultrasound for AVMs to look at the deeper AVMs. And my neuro-oncology colleagues, they use the intraoperative ultrasound all the time. And they've got good at it. And some of our radiologists also quite interested in coming to theater to help us with that. We find their participation quite beneficial.
Thank you. Thank you so very much.
I would like just to make a few comments.
Thank you.
And thanks very much for your outstanding presentation. I would just ask you, if you consider the unilateral interhemispheric approach, and as I started as you, and now I think we are more and more doing the interhemispheric approach for such lesion, as I feel that I can found the big vessel at the beginning when we are still not tired. So you can dissect the vessel just at the beginning, and you can separate the tumor at the beginning. Even though you can have more bleeding, as you know, you are not getting the dural touch first. Second, for my personal philosophy, I use to do, if you can go from both sides, I would say that dominant hemisphere, the left, so I go almost always, if possible, from the right side. I don't see to use a lot of the CUSA, and also drilling the base. I use more the diamond drill bit, and I think is much better to achieve a quicker hemostasis. Thanks very much.
Thank you. I think all these points are well taken. I also agree about the finding the blood vessels at the beginning rather than at the end of the operation when you're almost towards the end of the day and tired and likely to make some mistakes. But I haven't used interhemispheric approach for olfactory groove tumors, I have to admit.
Thank you.
There's another hand here, Dr. Kasimov, maybe next.
Yes, there is one question from Dr. Kasimov.
Thank you for good presentation. My question: how often do you use lumbar drainage when you was doing approach?
Yes, I think that's a good question, because I don't use the lumbar drain at all for most of my tumors. But having said that, the last 10 years, I have used the lumbar drain for one case when one of my colleagues did an olfactory groove meningioma with a lot of brain swelling, and he had to back out because the brain was so swollen. So when second time I also joined, and the brain, we knew that the brain was going to be so swollen. So in that case, we put the lumbar drain in and kept it closed till we opened the cranium, and it gives you some relaxation to get to the base of the tumor. But otherwise, I think if you're doing a lateral approach, often you can get to the base without a lot of brain manipulation and going into the cisterns around the optic and carotid nerve to get some CSF off. But you're right, in big tumors, and sometimes even that cistern may not be apparent, and the tumor may have gone into those cisterns and you may not get enough CSF. But generally, I would avoid lumbar drain, but I think in some cases, it has a role, and it may be used in some cases.
Okay, thank you.
Thank you so much. Let me introduce our next speaker, Dr. Abhiram Gabita, MCH, DNB Neuro, consultant neurosurgeon from Andrea Islam Jain's book, from Hyderabad, India. So today, Dr. Abhiram will be talking about combined Dolenz and Kavasi approach for petroclival meningiomas. Dr. Abhiram, please. Where is he?
Am I audible now? Okay.
Dr. Abhiram, where are you?
Yeah, am I audible now?
Yes, you are audible.
Yeah. Just give me a second.
Yes, of course.
Internet connection.
Okay.
Yeah. I'm sharing my screen.
Yes, please. Yes, done. Presentation mode, and we are ready
Yeah,
to listen. Done. Great.
Can you see my full screen?
We can.
Perfect.
Yeah. Good evening. Thank you, John and Nargisa, for having me here, and good evening to all the August audience. I feel very privileged to be in this panel, and my topic of today is a combined Dolan-Kawasi approach, that is joining the both masters for the petroclival approaches for petroclival meningiomas. I work in AAG hospitals as a consultant. I did my fellowship in neuro-oncology and skull base at SGPJ Lucknow, and right now I'm working in Hyderabad, India. So coming to this petroclival area, actually this is a very narrow area which can be approached either through anterolateral approach, that is satirional with orbitozygomatic approach, or a pretemporal transcavernous, which is essentially the Dolenk, and either subtemporal approach and with Kawasi approach, that is transapicopetrous approach. There are very important neurovascular structures around this area, right from the second nerve to seventh, eighth nerve, and petrous ICA and cavernous ICA. This is a very narrow space, and the tumors around this region are sometimes really a task. So in 2018, there's this nice paper by Leo et al. Saying that when we combine both of these approaches, that is Dolenk plus Kawasi, essentially the target area becomes at least 2.5 times more than the individual Dolenk or Kawasi. So that's why this is called combined Dolenk and Kawasi approach. There's a paper from AIMS from Manjul Tripathi and Ashish Suri sir regarding this modified Dolenk Kawasi approach, and also from Spedler et al. Now, the case point is this patient, a 38-year-old, who had left side third cranial nerve to facial nerve paralysis, and with brainstem compressions with weakness. Initially, he went to an outside hospital where, as we can see, a biopsy has been tried from the retrosigmoid approach. The tumor started bleeding, and they have abandoned it. And again, they started doing it through that subtemporal approach, and that also failed. So finally, when he presented to us, he was in a quite bad shape. So coming to the position and exposure, we usually keep the patient in 45 degrees turned to the opposite side. We can see the previous scar here. And the neck is extended, and the exposure, we usually do interfacial dissection, and also temporalis we do Oikawa technique, so that the temporalis vasculature remains the same. And once and we do zygoma shaping, reshaping. That is, we don't do orbitozygomatic craniotomy. We just do zygoma shaping, so that this small step gives a very big leap in this exposure. And coming to the surgical video, as we can see here, this is the frontal side towards the drill, and the temporal side towards the suction. And the first process in this combined Dolenk and Kawasi approach is the extradural clinoidectomy. Extradural clinoidectomy, the clinoid has actually 6 surfaces: the frontal surface that bends into the optic nerve, the temporal surface that bends into the oculomotor nerve, and an optic strut surface that goes into the ICA surface. So by this, I am showing the frontal surface that is going into optic nerve. And here the suction side is the temporal going to the oculomotor, and we'll decore. Instead of coming it from the outer sides, we'll decore it from the central part. And once this is done, we can see the optic strut surface, and This is the orbitomeningeal artery. Once we cut the orbitomeningeal artery and orbitomeningeal band and further decore, we can see that the clinoid is rocking. And we can remove the clinoid very easily. Here, we should not pull out the clinoid. We have to slowly dissect and remove it. And once this is done, we slowly move our focus towards the peeling of true cavernous membrane. That is, there are two important points here. This peeling of true cavernous membrane can be done from posterior to anterior and also from anterior to posterior. There are so many similarities in this approach. In the posterior, we'll find the band of GSPN, whereas anterior, we'll find the orbitomeningeal artery and the band. And we'll coagulate middle artery at the foramen spinosum in the posterior approach, whereas in the anterior approach, we'll coagulate the orbitomeningeal artery at the Hirschfeld's foramen. Combining these two approaches, we can safely peel the temporal dura from the cavernous without causing any contusions. As we can see, I did not even use a ventricular puncture or anything. Slowly, the temporal dura is getting separated from the cavernous dura here. And here, the most superficial landmark is the arcuate eminence, and there is always a bony ledge over the V2 and also V3. So we can slowly start drilling the temporal base. Backup sutures are being taken to the temporal dura so that no significant retraction is needed with the retractor. And this is the V3. As we can see that when the bipolar current is used, the temporalis muscle is nicely pulsating. And from here, we can see the face of this is the initial phase of the Kawasi rhomboid. This is not the entire Kawasi rhomboid. This is the initial phase where we start drilling it from the medial to lateral, because the Petrus ICA is at the lateral part above. So we should always drill it from the medial to lateral. And once this is done, we can slowly expose the second bump of the Petrus ridge. This is IGS navigation to confirm that we are in the Kawasi quadrilateral. And now here I could catch the middle meningeal artery at the foramen spinosum. And controlled it with further coagulation and bone wax. And after this, we can clearly see the V3. And this is the Kawasi quadrilateral now, which is being drilled. This is the arcuate eminence. And we can see the superior petrosal medially, and lateral will be the GSPN band. The Kawasi quadrilateral is being drilled with a 3 mm diamond drill. We can see that if this is almost 5 times, this area is 5 times the 5 to 6 times the diameter of the diamond drill. That is the excellent exposure we get, and the bipolar is confirming the GSPN. The strength of stimulation is noted, and here is the V3. One important landmark is the Petrus ICA runs below the GSPN, and below the V3 it is just below the GSPN. So we should not aggressive enough to drill it towards the anterior side, but posteriorly we can go till the arcuate eminence. And once that is done, this is the area where we can open the temporal dura, and we can temporal dura is being opened. And once that is done, we can see that the tumor that is in the cavernous and temporal base is coming out. The tumor is being sucked up with CUSA. We can see that the tumor has almost become bloodless. This is very important in a skull-based procedure, because We are devascularizing and denuding the tumor by doing all this skull base work. And once that is done, we'll slowly decompress the tumor and dissect it from the major nerves and vessels. So coagulating and cutting the superior petrosal vein. And this provides us an access right from the middle fossa to the posterior fossa. The tumor itself presents out. And once this part of tumor is removed, we can see we have gone almost till the brainstem, and this is the 7th, 8th nerve complex. And post-tumor excision, we can supplement the skull base defect with the fat and with glue. Post-operatively, we can see that it's a near total resection with a post-contrast scan showing no residual tumor. And this is the 3D reconstruction CT showing the reshaping of the zygoma. The temporal bone has been completely drilled. And in the volumetric 3D reconstruction, we can see that the entire skull temporal base has been encroached, and from here the access to the Kawase rhomboid has been there to the posterior fossa. Thank you. This patient did very well after 3 months. His third nerve palsy is still persistent, but he is now being mobilized. He's able to walk, and he's able to eat his food. His family is happy. Thank you.
Thank you very much, Abiram, for your nice presentation. Any questions, comments?
I can just say a very nice case. The only point that I would like to make is it is a pity for me to see such a good work then a little bit downplayed by the fact that the reconstruction was with a titanium mesh. I'm a big fan of single stage resection and reconstruction of the calvarial defect. And our philosophy here in Oxford is always to use PICC or any sort of other plastic for reconstruction of a calvarial defect, because this obviously will not cause any issue in terms of possible artifacts, imaging artifacts, if the patient is routine follow-up with MRI with contrast. Also, the plastic custom-made cranioplasty allows for possible consideration for radiation therapy, either in form of conventional radiotherapy, stereotactic radiotherapy, or gamma knife or cyber knife radiosurgery. And finally, obviously increases the chances that there will be no problem with the flap, because we know that the titanium meshes have very sharp edges, and over time they can lead to problems with the wound and be responsible for possible dehiscence of the wound later on down the line, and this is the number one factor for delayed surgical site infection as well.
Yeah, I do agree with your point, but it's our fault. While doing surgery, the bone fell down into the dustbin while the brother was handling it, so that's why we had to use a mesh.
Okay, any other questions?
Yeah,
Sir, could you? Yes.
Can I make a question? Thanks very much. It's a very nice presentation, very nice case. And the question is, do you perform systematically the craniodectomy? And if yes, what's the advantages in this case? First, and second one, and do you use fat to fill up the dead space and to close the dura? Sometimes when you go to the posterior fossa, making the Kawase approach, the anterior petrosectomy, and it's easy to suture up, to stitch up the dura there. Thanks very much.
Yes, so the advantage of clinoidectomy here is it helps in peeling the lateral wall of cavernous sinus. And yes, we always fill the skull base defects with fat and a little bit of glue so that CSF leaks and pseudomeningoceles do not happen.
Thank you.
Fine. I think I can move on and introduce our last speaker. As I always say, last but not least, Dr. Kazimov from the Neurosurgical Federal Center in Novosibirsk, one of the 5 federal centers in Russia. And today, Dr. Kazimov is going to introduce a talk on contralateral transfix approach for removal of brain tumor. So I think we will hear about all the transfalcine approaches and how to design and implement them in the operating theater. Please, Dr. Kazimov, the floor is yours.
Hello, everyone. I'm glad to see you. And my topic today, transverse contralateral approach for removal of the brain tumor. The clinical case demonstrates the relevance of this approach and show that preoperative planning is very important. The patient came to us. She was previously operated in one of the clinics of our city. And we see that there's still a tumor, and even though there was decompressive cranioectomy. We used a contralateral approach through a small craniotomy and removed that tumor. Features of tumor of the interhemispheric fissure. Brain veins draining into the superior sagittal sinus. Cerebral edema on the site of the lesion. Absence of cerebral edema on the contralateral side. Option for approaching a tumor on the interhemispheric fissure. We can use ipsilateral approach, and we can use contralateral approach. In 1984, Almeida first described the contralateral approach with dissection of the falx for the removal of parasagittal AVM. In 1995, Apulgael first described the falx approach to the contralateral cerebral hemisphere tumors. Indication for the approach: tumor contact with falx, localization of the tumor below the superior sagittal sinus, cerebral edema on the site of the lesion, absence of cerebral edema on the contralateral side, and recurrence of the tumors in the contralateral side. For example, female 60 years old, recurrence meningioma in the contralateral side. Previously, the patient was operated in one clinic in the city. We see tumor recurrence in the contralateral side. We didn't use a new approach in the tumor side. We did a small craniotomy in the last craniotomy. And after craniotomy, do you see video?
No, we cannot see the video. We see only a frozen image.
Yes. No,
Now
now we
it
can see the
started.
video. Yes.
Now it started.
After craniotomy, we access the falx. In this case, there was an advantage due to the fact that there was a postoperative cyst. This gave free space for manipulation. Then make falx incision. We are visualizing tumor. We are removing the tumor. We can see postoperative MRI images. There is no tumor, and MRI before and after surgery. In our experience, we had 24 patients. According to histological conclusion, the patient had metastasis, meningioma, and glioma. According to localization, we divided falx into anterior, middle, and posterior parts. All patients had cerebral symptoms. 58% patient had focal disorders, and 33% had convulsions. Preoperative planning of this approach is very important. We use MRI to plan safe and appropriate approach. Depending on localization, we used supine, semi-sitting, and prone position. Always we use intraoperative navigation. Craniotomy should be with exposure of the superior sagittal sinus up to 50% in diameter. We never use retractor. A key role in the successful application of this approach, it is skin incision, craniotomy, and transitional veins, part incision. We can't make mistakes at these steps. Results. Average operation time, 1 hour, 50 minutes. Blood loss medium value, 105 milliliters. All patient had gross total resection. 80% regression of symptoms in the early postoperative period. There was one case complication of the hemorrhage in the cavity of the removed tumor, but this patient didn't need reoperation. There is no additional neurological deficit. There were metastases in most cases. For example, the first clinical cases, male, 65 years old. We can see tumor on the left frontal lobe. We can see peripheral edema. We can see the tumor localized in the functional zone nearby central gyrus, and we used contralateral approach. We do craniotomy on the lateral side, and after opening on the durometer, we are dissecting arachnoid and vein. Then we access to interhemispheric tissue. We are making falx incision. We are visualizing tumor. We are removing the tumor and saving nearby vessels. MRI postoperative. There is no tumor. It's a T2 mode MRI, and before and after surgery. There is no tumor. The second case, man, 60 years old, had metastasis on the right frontal lobe, deep localization, and we can see peripheral edema in the ipsilateral side. And we use a contralateral approach. After opening the durometer, we are dissecting vein and arachnoid. After that, we doing skin falx incision. After that, we accessed two tumors and visualizing the tumor. After that, we detecting on peripheral, and after mobilizing this tumor, we are removing this tumor. And we can see after removing this tumor cavity is very small, and there is no vein damage. MRI post-op T2R mode. We are looking at post-operative MRI images with contrast enhancement. We do not see the accumulation of contrast agent. Before and after, and follow-up was 2 years. We are looking at MRI images 2 years after the surgery. We can see that there is no recidue. There were meningiomas in 33% of the cases. The clinical case female, 52 years old. She had disease neurofibromatosis type 2, and we can see a meningioma in the temporal lobe, and we can see peripheral edema, and the tumor localized in a very important and functional zone. We used the contralateral approach and MRI post-operative T2R mode and contrast with T1 contrast enhancement. And before and after, there is no tumor, and MRI images 1 year after surgery. There is no recidue. There were glioma in 30% of cases. The female, 45 years old, she had astrocytoma grade 3. It is cingulate gyrus glioma. We can use we used the contralateral approach for removing this tumor. MRI images 2 years after surgery. There is no recurrence. Advantages this approach: absence of cerebral edema on the contralateral side, no traction injury to normal brain tissue over the tumor, no brain vein injury draining into the superior sagittal sides, navigation, no brain shift before pulse incision, rapid devascularization of tumor roving from falx, meningioma, and metastasis. Radical removal of falx tumors together with the source of growth. Disadvantages and risks. Limitation of wide visualization of the cavity of the removed tumor. Difficulty in visualizing bleeding outside of the falx. Good macrosurgical skills are the key to success. It is not recommended to carry out such operation by neurosurgeons with little experience. In conclusion, the transfalx contralateral approach can be recommended as an alternative option for the treatment of a number of patients with tumors of the interhemispheric fissure, as effective, minimally invasive, and less traumatic. Thank you for attention.
Thank you very much, Dr. Agadadas, for detailed presentation. Any questions and comments? Dr. Mario?
Yes, basically,
Dr.
while I see a very good indication for this type of approach for all lesions that have a dural attachment, I think the scope for considering a Trelfan approach in any type of gliomas, you show a grade 3, would be much less common. This is not to say that this approach might not have its own advantages even in this type of tumors. And from my point of view, basically, I would like to know whether the consideration for your approach in the case that you have showed was almost related to the fact that the lesion was also crossing the midline below the falx, and this might have represented the indication, the golden indication for considering this type of route.
Thank you. Dr. Andrei, do you have any other major comments? Could you unmute yourself, please?
I'm sorry,
Yes.
I have forgot to switch on my mic. Thank you, Agadadas, for nice presentation. I do think that this approach it has place, and a lot of literature is in peer-reviewed journals concerning this approach. And I have to ask the question concerning the position. Do you have an experience of park bench lateral position, or you use only supine and prone positions for this approach? And if you have an experience of lateral position, what kind of position would you use in such case?
Depending on localization, I use position at supine, prone, and semi-sitting. I never use park bench position for in the contralateral approach.
Okay, thank you.
Thank you so much. Any other comments, or should we come to conclusion? Okay, probably for today we are done. I personally want to thank you, everyone. I think today was really interesting and one of the difficult topics with all details from big bosses and professors. Thank you so much one more time. Today is our 7th webinar, and I'm glad that in these 3-4 months we could and invite around 24 faculties from Russia and other countries. So we are moving forward, and the next webinar is going to be 14th of January 2024. We will be talking about functional neurosurgery. Most welcome everyone who wants to join, participate, and be the panelist. Thank you, John, for all your effort which you put. Thank you, Dr. Mario. So I think we can say Merry Christmas and Happy New Year. God bless. So we'll see you next year.
Thank you, Nargiza. You're pretty upbeat for someone that's at the airport. She spent the last 24 hours stuck in the airport, and I appreciate her dedication to neurosurgery to be here to bring this wonderful webcast together. You know, there's 2 parts. There's communication and education. Good communication leads to good education. And today is a huge day in education because it allows us to get real-time translations of languages. Real time means now, I mean, which is a tremendous step. So a webinar like this can potentially go to like 160 languages live. I'm not talking recorded, I'm talking live. So this is a tremendous day, and we look forward to the future, and we'll see you in a couple of weeks.
Thank you so much.
Merry
Thank you,
Christmas.
Professor Kebara.
Thank you, everybody.
Thank you.
Thank you,
you.
everybody.
so
Merry
much.
Christmas to
Yeah.
those
Merry
that are
Christmas.
celebrating today and tomorrow, and for our Russian friends next week. Okay.
Next week, yes.
See you
Thank
next
you
See you
so
in the
much.
new year.
See you next
We
year.
will
Yeah.
see. We will
Thank
be
you.
in touch.
Bye.
Thank you so
you.
Bye
much.
bye. Bye bye.
Perfect.
Bye
Bye.
Bye-bye.
Bye bye. Bye. Thanks.
Bye, John. Thank you so much. Bye.
Bye,
Okay,
John.
thanks.